Okay.
Give me 1 second. This was 27-year-old patient. Came in with right flank pain. So I'm showing T2 weighted images, high B value diffusion images, and I'll show you the ADC. In and out T1. And then post contrast. So just want to know what differentials would you have given and how would you have prioritized your differentials?
Is it a female, like a middle-aged female?
She's 27 female.
Because I'm thinking about a MEST tumor of the kidney.
I know. So the age was a little off, even though that's bimodal, she's kind of not young enough for the young peak and old enough for the old peak, right?
Yeah, I still think it could be just given how cystic, but then like those solid septa.
Right, so that was my conundrum. It was not herniating like it should, but we've seen some that didn't necessarily.
But Roopa, the ones that herniate are the multilocular cystic nephroma. I'm talking about MEST. Does MEST herniate?
I thought MLCN and MEST are now along the same spectrum.
Oh.
Regardless, based on diffusion and ADC, I didn't think the septations looked very ugly, nodular. They look like thin and enhancing septations. So I actually ended up favoring a MEST on this. But path just came back and it's a clear cell RCC.
Oh, wow.
I know. So imaging wise, what other pointers would you have prospectively used to, or would we have put a clear cell over a MEST, or how would we have gone about? So I just want to know any thoughts or opinions. One other thing, looking retrospectively, this vessel looked like super dilated and like it was feeding it. So is that a sign of neovascularity, and hence we would favor this as being more RCC, but no other nodal disease, no real invasion into any of the adjacent structures. It's a deceptive one for me.
Absolutely. Does anyone else have input about whether they would have, because I guess like even if I'd favored a MEST, probably it's still a surgical lesion.
Probably.
Yeah.
Yeah, and that's what we said is they were anyway going to do robotic partial nephrectomy. So let me show you the post-op images. So again, another terminology question. Find the correct sequence. So she had a large bleed after surgery. So we ended up doing a CTA type protocol, if I can find the images. Okay, let me share screen. Okay, so this is immediately the day she came out of the OR and we did this CT scan. So seeing a lot of hypo-enhancing areas in the remainder of the kidney where they didn't even necessarily operate, seeing a big hematoma in the bed. And then what would you guys call these foci? Let's see if there's another phase where this is the more delayed phase. It sort of persisted, looked very tortuous. Is this that same neovascularity which was there, or would we call some of these pseudoaneurysms? So we kind of just described them, had no specific.
I think I would have called them small pseudoaneurysms.
So we kind of hedged a little bit. We said they may have been residual neovascularity, but cannot exclude pseudoaneurysms. So IR actually went in. They said they did not find any pseudoaneurysms, but what they found was a dissection in one of the renal arteries, which I guess accounts for these being infarcts. But they didn't do anything about these vessels. They just said there was little residual hypervascularity and no real pseudoaneurysms or active extra.
Do you have an arterial phase? I was just curious if we could see the dissection.
No, that's what I was looking for. Hold on 1 second. Let's just go through all these phases again. That's pre. I guess this is the most arterial I've seen so far. Not really, Aarti. I thought we did this as a CTA, but no.
And it's an interesting complication. I haven't seen dissection after a partial nephrectomy.
Exactly. Causing extensive infarcts, right? So yeah, from pre to post-op, this was a very puzzling case. So I just wanted to get a little more feedback and mainly wanted to know what terminology we would have used for this other than just describing it.
So they did say though that it looked kind of tortuous, like in the on angio, like but basically call it neovascularity.
Yeah. They didn't think there was anything to embolize, basically.
I feel like I've seen this before with hematomas, and I always think it's like the hematoma spreading out the vessels and kind of had like sheared them, like there's some kind of post-traumatic, almost like pseudoaneurysms, but I guess that's
right. That's kind of what I told my resident is that these were vessels which were already there, and when they cut in, they tore through previous tortuous vessels or something like that, right?
Yeah, lucky for her that it got resected.
Yeah, she's doing fine now, so
good.
Yeah.
Okay, who wants to go next?
I can do it. Unless you want to.
No,
Hi,
go.
Aarti. So good to hear you. Okay, let's see. So make sure. Okay, hold on. Cases. So a couple of quick cases. This was a young woman in her 30s. This was an outside MR. I'm not sure why MR was done originally, but there was this lesion in the bladder. Let me just move this up. And you can see that kind of like, kind of low signal intensity in T2 and kind of brightish signal intensity in T1. Here's the sagittal post, kind of right there. So it's unclear what it is, but didn't really look cystic. So any thoughts? Just based on.
It's a good location for a urachus.
Right. So
I like also endometriosis. I was wondering if she had adenomyosis. Oh wait, no wait.
Wait, so this is like a follow-up. So the original, you can see here that her junction zone is not that thickened. I agree, like with the signal characteristic we saw, probably endometriosis would have been my thought. And it is a great site for urachal cyst. So she came back and, a few months later, and this was kind of there. It wasn't as great of a study. Basically, this ended up being resected. And this was a resected, path-proven urachal cyst. And that just, so it was very unusual because it was so not cystic,
Maybe it has like protein in it or something.
Yeah,
blood
no,
or
it
protein.
must be, but unfortunately, because the bladder feeling differences in, before and after contrast really couldn't, there's not a single place where we could show that there's no enhancement. So anyway, so that was kind of interesting. All right, let's see.
Victoria, the diffusion didn't help on that either.
I'm sorry?
The diffusions didn't help.
The what?
The diffusions?
This was an outside study. I don't think it had
Didn't
diffusion. Oh no, it did. Sorry.
Yeah.
I had, go ahead.
Not sure you can see.
Only too much volume averaging.
Yeah.
Yeah.
I had a case similar to this, and a patient with endometriosis, and it was, in my case, it was T1 hyperintense, T1 bright. And it was a little bit more posterior and at the dome. So we had called it endometriosis at the bladder dome, and the patient went to OR, and there was nothing in the OR, and then we got a repeat MR, and it was gone. And so the patient was on intermittent catheterization. And so after the second MR, when we met, we thought that maybe that T1 hyperintensity was just from the hematoma that the patient probably had after with CIC. And that was that's why maybe the location at the dome. So it was something that was it didn't really think about until we got the clinical history of CIC and seeing the result. I mean, it's a tangential finding or a case to what you're saying, but we can see this with so having that history was very helpful in our case.
Okay. Awesome. So the next case is sort of insane. So this is a young woman, 20s, 30s, something like that. Also outside MRI, sent for second opinion. And you can see that, we have a big mass, right? Kind of almost iso to the liver on T1, has very nice kind of enhancement on arterial phase. T2, you can see, has a very kind of heterogeneous. So, on T1 and, on the pre and arterial phase, you could potentially think maybe this is some sort of unusual FNH, but look at the T2, it's just such an ugly, heterogeneous, almost target-like appearance. But, it does have kind of the peripheries a little more hyper intense. Which makes you think maybe this is some sort of unusual appearance of inflammatory adenoma. She's a young woman again. And then here's the delayed images. You can see that the lesion sort of becomes pretty much iso-intense to the parenchyma. And you can see that there's maybe some retention of the contrast in the areas which were originally T2 hyperintense, which again goes very nicely for inflammatory adenoma. So let me just grab the CT because it has a nice CT as well.
Victoria, remind me, the T2 brightness around the periphery, is that the atoll sign?
Yeah, it's not as nice of atoll sign as I've seen usually. Usually it's like the inside is very homogeneous, like you would see internally, it's really homogeneous, and then kind of very similar to the parenchyma, and then you have this kind of rim. But you'd think this is a big lesion, so maybe that's why the heterogeneity comes in, and it really does have like a very nice behavior on the contrast, considering its size, right? And here's the CT. Oh God, I don't understand why. Hold on. Okay, so you can see that the lesion is heterogeneously enhancing, becomes, again, the rim retention is there, but the parenchyma, if you just pay attention to that, it kind of iso. Anyway, so the interesting part of this case is that, it's a big lesion. We thought it was inflammatory adenoma. The patient was sent for a biopsy, and the pathology came back as inflammatory adenoma with some beta-catenin activation. Because of the size, or I assume because of the size, the decision was made to remove this lesion. And the final pathology came back as HCC arising from the background of inflammatory adenoma, which is super unusual. But unfortunately for this patient, that's what the path came back.
Wow, was it well differentiated? Do you know? Because it seems so.
For
the size, it doesn't look as heterogeneous as like a really.
Let me get back to. I believe so. I have the entire report saved somewhere. I just don't want to. I don't want to futz around because I'm afraid I'm going to flash PHI. But it was well differentiated, but it wasn't like a little focus of HCC in a large adenoma. It was basically mostly HCC with background adenoma, which was very unexpected in this case, because there's really nothing here that's so outrageously, scary.
Yeah, it's like not washing out at all. But I guess
Yeah,
that
no.
beta-catenin must have been helpful too to like push towards resection.
Right. But I think here it was just a huge size and yeah. Well, I actually don't know. I assume it was size. It potentially was also beta-catenin activation. Although if you like the path from the biopsy was very, there was no, sometimes, the pathologist will say, can't really exclude this, can't, or insufficient material to really exclude that. It was none of that. It was basically inflammatory adenoma with some beta activation here and there. So it was very unexpected finding. And this is the diffusion again, like it does have the, targetoid appearance, which, once you get, I don't know, I always get nervous when I see that. But anyway, so that was a very interesting and unusual case.
Victoria, was she not a typical age for an adenoma? Is she a little older?
She's 25-year-old woman. I don't know how she got how she presented, only because this is I read the follow-up. I already read after she was resected. So this is pre-resection, obviously. So I'm just looking at the reports, and this was done at the outside study, and all we have is liver mass. Please evaluate. So.
Yeah, we've seen this too, where once adenomas grow over 5 centimeters, I think it's very hard to. We've also run into this where the final path has come back HCC, and then you wonder, would it have been treated differently had we prospectively said we cannot exclude, or what? Does the T2 heterogeneity help us in any?
I'm just gonna have to 5 minutes. You need to wait 5 minutes. Okay, sounds good. Okay, all right. So this is my last case. Let's see if I can bring this up. It does not have. Hold on, see. I need to put full annotation on, but I think that I annotate. Okay. So this is the reason. Okay, so this is an older case, but it demonstrates one of my pet peeves, which I think I've talked about before. But again, this is so you can see that this patient had cirrhosis at some point. This is a fairly old study, and you can see that we have an in phase and we have an out of phase, and you can see that there are multiple tiny little dots that we see on the out of phase, and we don't see that on in phase. So thoughts?
Iron deposition. Heard that out of phase, the TE is later here. So
right. So this is one of the things that I keep been very residents and fellows think I'm very persnickety, but I keep making them change things. When they say signal loss on the in phase consistent with iron deposition. And the importance here is that it's not the in phase, it's the TE. So in this is an older case when TE was done as a second, the out of phase was done as a second echo. It still happens sometimes, even in current scanners, when the tech just inadvertently changes the settings, or sometimes whatever. So if you're not paying attention to, to the TEs, you may not, if you just remember that the signal loss from iron should happen on an in phase. This isn't, you will never get this case correctly, because you start thinking about some funny steatosis and things like that. So this is just a reminder that it's not the in and out of phase which determines where the signal, loss will be due to iron. It's the whichever one is the second echo. That's where the blooming will happen. Anyway, so that's it for me.
Great reminder. Thanks for sharing. Can I share a case?
yes, go.
Okay, great. Would you be able to pause it, please? I want to. Thank you. This patient presented to us initially with this finding. Any thoughts? Here's the axials. So obviously there's a mass, and it's metastatic. Patient does have a history of melanoma, and this was the presentation. So it was resected. Patient did well. The melanoma ended up to be in like one of the extremities, and the patient did remarkably well and became NED, no evidence of disease, or multiple imaging follow-ups, and then had on a subsequent imaging follow-up had a new finding in the left gluteal soft tissues. Any thoughts about this? I'll show you the axials. Can you all hear me? It's so quiet.
Yeah.
Okay,
I'll
great.
participate. I
Okay,
mean,
great.
normally
Thank
with
you.
melanoma, I get concerned with subcutaneous stuff.
Yeah.
Although often it's round. This almost looks like it's like following like a linear fashion, but I'd still kind of have to raise a suspicion.
Yeah, exactly. So we said, this is new. The imaging exam before that was this, and there's nothing there, right there. And but maybe there's something on the right. I don't know. But so on the left side was new, and so we said, oh, I think, like you said, like it's concerned for different metastasis. And so
No,
then
wait, I have a question. What is
Yeah.
that thing on the right? Like, because I was thinking this thing almost looked like a thrombosed vessel on the left, but like, and it does look like they have a similar like weird vessel on the right.
Yeah, exactly. So then I read the follow-up, and then now that left thing is gone, but there's a thing on the right there. And then now there's this thing on the right that looks just like the thing on the left. So I dig into the notes because I'm like, why is this patient on treatment? We had already called it, XYZ. And so this turned out to be a hormone pellet, a testosterone hormone pellet. They
Whoa.
injected. So I know it's usually in the gluteal soft tissues. It's like I think they do it every 3 months. This is an alternative option for testosterone hormone replacement because it lasts a little longer because it's slow release, and it has this little like cigar, like you said, cylindrical shaped thing, shape to it. And so when you go back, you're like, oh my God, it does. So just FYI that thing exists. And so this thing had already resolved because, I think it lasts like 3 or 4 months. And then they inject the other side. And that's why we saw it before, like what you had said earlier, right? On the right side. So this is what just FYI, a hormone pellet therapy.
That's very cool. I always see these with lenriotide injections, like, things that come and go in the like big gluteal granulomas. I have a question. Why? I didn't know they treat melanoma with testosterone.
No, this was not related to testosterone, and we had advised against it. But people, it was not done here. It was, whatever supplemental stuff that the patient was doing outside of the oncologic care.
Got it. Okay.
Yeah. And I don't know. I mean, I don't know if I found out that in Arizona, you don't like naturopaths. They are like physicians here, and actually NPs and APRNs, they don't need physician supervision to do prescription and various interventions, therapies. Yeah.
Cool. Thank you. Learned something new.
Yeah.
Okay, we'll go back and forth. So this is my patient. They are a 40-year-old female. You can see this is the uterus with some fibroids.
Can you show me the appendix? The appendix is okay.
Let me see if I can find it. That's a great thought. So what are you thinking?
Well, I was like you can have a mucosal. It looks kind of lobulated and encapsulated. So the other thing that I was thinking was it was some kind of mucinous something, either coming from the ovary, like a ovarian mucinous neoplasm, epithelial or appendix, or the other thing I was thinking was like trapped, like a peritoneal inclusion cyst if the patient had surgery in the past.
Perfect. So that's everything we were thinking. Like, is this pseudomyxoma, or is this a peritoneal inclusion cyst? There is something interesting about it in that, like, there's all these septa, so it's a little bit different looking than usual. And I will tell you, in the end, the diagnosis of what this is, the ovaries, the appendix were all normal. Does anyone?
Patient is not on like hormone therapy, right? Like Clomid or anything like that.
Nope.
And then the other thing that comes, I don't think it comes. This is probably low. Salpingosis was something that comes, but I don't think they're that big. They're little dots of T2 hyperintense foci.
What about a lymphatic malformation of some sort?
Oh, that's a good one.
Yeah. So that's the other major thing to think about. And what ended up the final diagnosis is not something we normally think about, but that's why I wanted to show it. So this turned out to be.
It has a very tubular component. Sorry, like right there on the cranial.
Yeah,
some
this
kind
guy.
of tubular thing, like I don't know if it's a dilated fallopian tube or there's some kind of
Nope, none of those things.
Oh my God.
So it turned out to be a benign multicystic peritoneal mesothelioma, which is called a BMPM. You can Google it. But anyway, so just so you guys know that this exists, it is a multicystic benign neoplasm. It arises, it's lined by mesothelium. That's why it's called a mesothelioma, but it's the benign version of a mesothelioma. It's usually in young females. It's pretty rare. They say there's like 200 case reports, but I think probably it's more common than that. And it frequently recurs. So even if they resect this, it'll recur, it like 50% recur. The treatment is resection and with or without HIPEC. So they're treating it kind of like pseudomyxoma, but it is a benign thing. Extremely rarely it'll have a malignant transformation, but it does recur. So I guess one of the clues is the fact that it's kind of this multicystic thing that would, with these true septa, that would kind of go against a peritoneal inclusion cyst. But otherwise, I think, yeah, I would have said lymphangioma or, concern for pseudomyxoma. But just so you know, it exists. And not everything that has mesothelioma has a really bad prognosis. Yeah. Nelly, do you want to show another one?
Yes, may I?
Mm-hmm.
Okay. Let's get a known HCC. A history of known HCC, had prior local regional therapies and was just on the transplant list, awaiting transplant and, surveillance of the treated lesions. So the patient eventually got a transplant, and I have the explant pathology. So I'm showing this because I think this is hard. So anyways, what do you guys think? Let me
Do you want us to focus on that enhancing thing in the left lobe?
I do, but whenever I do things, it's so nice to see the history, like the original tumor and stuff. So maybe I should do that here. Let me see if there's a more recent one, so that at least we know the follow-up, because these patients often have a lot of. So this was the original HTC. Let's see if I can give you the study. The treatment wasn't done here. The patient was just being followed here for a transplant referral, but all the treatments were done at a different institution. So I think this is original. So anyways, I don't know if this was pre or post treatment, because it looks like there's a treatment effect. But anyway, this was one of the treated lesions, and then we had been, and that was done a couple years ago. We had been just following and treating. So let me see, this is so, oh, here it is. Oh, here it is. Oh, now it's blossom. Okay, great. So here was the original HCC. That was, and then I think that we got local regional therapy. There's a little dot there. Don't know what that is. And then we got serial follow-up. And then this, let's see. Yeah, this was, now it's dead. Now there's that little dot here that we saw before. Maybe it's getting a little bigger. That little wedge shape thing.
No, you're
and
reminding
then,
me of why I hate reading these post-treatment studies.
oh yeah, I have to go through like from the beginning, because otherwise I get so lost, right? Because there's like 6, 7 different lesions. One's been treated, one's not, one's new, one's old, and you're like, ah. So I always just start from the beginning so that I get my head around it. So this is the original image that I showed you. So now that we've seen this treated lesion here, the excavated lesion, which is dead, and that little lesion here, what do you guys think about this lesion? This is probably growing, maybe.
But it didn't wash out, right?
Let me show you maybe the
It looks
washout.
concerning to me. Just
Yeah,
like
for
given
sure.
how avid the enhancement is.
Yeah, for sure. Here's your washout. Let me see if I can put them side to side. So I don't know if that would be easier. So okay, so it was here. So my daughter it's half day today, recess. So you're gonna hear a beautiful voice in the background with lots of questions and inquiry very soon. And repeated button pressing of the doorbell. Okay, so all right. So I don't think it had washout. But it's this avidly enhancing. Hi, baby. And then, okay, what else? What other questions do you have?
Any ancillary features, diffusion, T2 bright? I mean, I'm thinking right now it's like an LR4.
Yes, and now that's what we gave it, an LR4. And I don't think the DWI helps. And we gave, and this, and I'm showing you this because this turned out to be cholangio. Yeah.
Was that supposed to be like targetoid?
Yes, it was. Yes, it was.
I was wondering what that dot in the middle was, but
yes. And so I was like, no, I was reading the post-transplant follow-up. So I had the explant pathology, and I went and reviewed all the images, right? Because it's so. Yes, so that little guy, this was HDC, that the dead HDC, although there was still like 5mm focus of viable goods in there, HDC, this turned out to be cholangio, and there's 2 other little dots of HDC. This little thing turned out to be HDC, and then there was another little enhancement somewhere that turned out to be a tiny HDC, and this was cholangio. And so I'm sharing this with you, and I'm going to show you a little document from the guidelines or something like that. Let me see, making sure I'm moved. Yes, baby.
Did you know your hand is bigger than your head? It's a sign of low intelligence.
Oh gosh, okay. I'm in a meeting. Can I talk to you later?
Mommy,
What?
Try it.
No, I can't do it right now. I'm in a meeting, Allie.
Try.
Sorry. What? Okay. All right.
So, did you know if your hand is bigger than your head, it's a sign of low intelligence?
this is good information.
Okay. Go away. Go. Thank you.
That's
All right.
rude.
I'm sorry about that. Okay.
That's amazing.
Yeah. Okay. I'll talk to you after. Okay. So anyways, there's a transplant oncology consensus conference guidelines. This was from 2020, last year. And cholangio, right? And mixed the biphenotypic subtype. So this working group issued the consensus statement. And so for cholangiocarcinomas, unresectable after neoadjuvant chemo, right? You don't do transplant for biphenotypic typically. That's not something that's offered. And then obviously for like HCC we do, but this statement was for cholangio. So liver transplant for I'm sorry, I should have PCCA was okay. I was intrahepatic. So there's different types of cholangiocarcinomas. We have the intrahepatic, the ICCA, and we have the perihilar, PCCA, and you have the intraductal. I don't know if that's separately labeled or not, but so for the perihilar, liver transplant for perihilar cholangio can be considered in patients with unresectable disease after neoadjuvant chemo in centers with specific protocols. So perihilar cholangio, unresectable, may be considered. And then you have the intrahepatic, which is what this patient was, intrahepatic. So let me see, patients with very early intrahepatic cholangio single tumor less than 2 centimeter and cirrhotic may benefit from upfront liver transplant. And then for biphenotypic type, HCC cholangio is currently not, the biphenotype is not an established indication for liver transplant. So I don't think it was bad that this patient got a liver transplant. I think the lesion was under 2 centimeters, but I think this, I mean, it wouldn't fill the criteria because the patient already had HCCs and other complications. But this is a working group endorsement on the role of liver transplant in patients with perihilar, unresectable perihilar cholangio and intrahepatic early single cholangio. And then biphenotypic, there's no indication for a liver transplant.
That's really interesting because I thought cholangio was essentially kind of a contraindication for transplant. So, and it also sounds like they think biphenotypic is worse than an early intrahepatic cholangio, which is interesting.
Yeah, I thought that maybe it wouldn't be, but I think maybe there's not sufficient literature. I don't know if it's worse or not, but.
I do have one comment about the perihilar ones. So we're one of the centers that does transplant for those. And but most of the patients don't do that well. So they're not super enthusiastic about it. But basically it's like people who have a Klatskin tumor, and if it's just the bad location, but the patient otherwise has all sorts of other good performance status, then they can get 6 months of chemo rads. And then if they still haven't progressed, then they can get a liver transplant.
That's awesome.
Okay, so this is my case, next case. So here is a mass in the left upper quadrant, and I can't see the chat, so you guys need to speak up. Got a lot of air in it. It's got a lot of enhancement. It's touching the pancreas.
Yeah, pancreas. Yeah.
It's also touching some small bowel loops here.
No recent biopsy or intervention.
Nope.
So I wonder where the gas is coming from. Well, I guess where is it arising from? I mean, initially I thought it was a pancreas, because it looks like it's
pretty exophytic to the pancreas. It is touching it.
Yeah.
You'll see that
there's a bowel right there, duodenum. Is it arising from the duodenum?
Yeah, or like maybe even the proximal jejunum. So what do you think?
Yeah, I was thinking gist. And then what else in the differential? I mean, adeno, I don't think they enhance that way, but sure, why not?
Yeah, and it's very exophytic. It's very mass-like. So adeno, unusual for adeno, which would be like usually more apple core-ish. Anyway, this turned out to be a gist of the proximal jejunum. Gists actually not infrequently have air within them because if they arise from the submucosa, the pacemaker cells, but if it erodes through the mucosa, then it'll get air in it. It's not a sign of aggressiveness when you have air in it, and it's also not a sign of infection. It's just a sign that it's eroded through the mucosa. So anyway, they gave this patient Gleevec. It shrunk a little bit, didn't shrink that much. They resected it. And because it was actually a sticky one, it was sticking to the pancreas here. So they had to do a distal pancreatectomy. And then this is the post-op. So you can see that this is the remnant pancreas. This is the suture line for the distal pancreatectomy. And then this is the resection bed for the distal pancreatectomy and the gist bed. So any thoughts about the resection bed here? There's a bunch of gas or air.
Like fat necrosis.
Yeah. Why and from what?
Have they packed it at the Surgicel or something?
No Surgicel, but they packed it with something else.
Omentum, like an omental flap.
Another torsion.
Yes, exactly. So they packed it with an omental flap. There was a big space here. They wanted to, so they'll do these omental pedicle flaps if there's a big negative like cavity, and also to promote healing. And then if that omental pedicle does not have enough vascularity, it can necrose, and then it can have a lot of gas in it. So it does not necessarily mean infection. So this was a necrosed omental pedicle flap after a gist. Okay, Nelly, you're up.
Okay. Yes. Okay. So this patient has a history of neuroendocrine tumor, and I was treated, and I thought that this was like a really great call from one of my colleagues. She had called this lesion in the duodenal bulb right there. Let me give you the axials. What do you guys think about that?
Neuroendocrine.
Yeah, right there. So
Gorgeous. And it also reminds me that we often forget to look at the duodenal bulb.
that's, yeah. So it was a really great call, and they sampled it, and it was pancreatic heterotopia.
That's cool too. Ectopic pancreas.
I know. I feel like that's it's
Oh
always.
my God. You know, it'd be even cooler if it was like a neuroendocrine in an ectopic pancreas.
Yeah, that would be way too.
I
cool.
actually have an ectopic pancreas in the stomach that had an IPMN in it.
Oh, is that right? Oh, wow. Oh, wow.
Yeah. Because ectopic pancreas can have all the same stuff regular pancreas can. Oh, you're done already? Okay.
Oh, yeah. I can pull up the next case, but
Here, okay. Okay, this is my next case. What do you guys think? So really dilated pancreatic duct. And then this is what the pancreatic head looked like.
It looks like pancreatic cancer or something arising from an MCN or, something bad.
Okay, that's a thought. So every time you see a dilated duct, we think adenocarcinoma. Could it be a main duct IPMN, chronic pancreatitis? I don't see any calcs. Anyone else have any other thoughts about this pancreatic head?
But I want to say something with those papillary fronds thing that you always talk about.
Okay, so you were like, oh, is there malignant degeneration in an IPMN? Anything else? Arkansas, I'm waiting for you guys.
Are there too many cysts that are close together?
Yeah, look at all these baby cysts
Yeah.
along the edge here.
Let's do an MR and see what it looks like.
Okay, so what do you think though? Like, what could it be?
Like a serous cyst adenoma which became a cancer, or is it obstructing the duct and the ductal?
Okay,
stuff?
but can serous cyst adenomas of the pancreas become cancers?
Typically not, right? That's why we let them be and we don't do anything.
Yeah. So my pathologists believe that they don't turn into cancers. They're not premalignant, but I think this is a beautiful example of something that looks like it could be a solid mass, maybe even with papillary fronds. But one of the clues is like all these little cysts here. So is this a serous cyst adenoma? And if that ever crosses your mind, you should just do an MRI because you'll see the cystic nature better. And then the other question is, can serous cyst adenomas obstruct the pancreatic duct?
Yes, we've seen one which did obstruct the duct. I guess it depends on if it's very strategically located, it can cause ductal obstruction. And this looks so smooth and
yeah, so this is the
long
MRI.
standing
So
dilation.
you see the duct is super dilated. And then what do you guys think?
it's a good location for a serous cyst adenoma, just bad because it's causing ductal obstruction.
Exactly. So this is a beautiful classic serous cyst adenoma, like microcystic. All these are little septa. These are some of the bigger septa, bigger cysts. They get a central scar, and that central scar can be fibrotic, and that also can contribute to this ductal dilation. So when they're big enough, or if they have a fibrotic central scar, they can cause ductal dilation. That is not a marker of malignancy. And in general, these guys are completely benign and don't cause malignancy. In this case, the duct was getting like progressively dilated over months, and the patient was having symptoms. So they ended up resecting this lesion, and it was a serous cyst adenoma, benign. So take home point, if you see a solid looking mass on CT is really bad for serous cyst adenomas because they can like mimic solid masses. But if you see like little cysts along the edge and you have any idea that, any thought that it could be a serous cyst adenoma, get the MRI. And they can cause ductal obstruction.
Aarti, the reason why they took it out is because of the pancreatic duct dilatation or the size?
Yeah, and she was having a lot of symptoms.
Got it.
Yeah, but we were calling this serous cyst adenoma the whole time. I have seen people like hedge like, oh, there could be malignant degeneration. But my pathologist said like, there's no such thing. If there is, like, extremely rarely, I think there have been some case reports And actually at BI, we had a case where there was a serous cyst adenoma with a neuroendocrine tumor in it. And we think it was basically a collision tumor where they were kind of coexisting, but it didn't arise from the serous cyst adenoma.
That makes sense.
I think, can I show a companion case?
Yeah.
So similar one. Do you see my screen?
Yes, that's huge.
It's huge.
Beautiful.
This one was nice. Same thing here, like there's ductal dilatation upstream from long-standing obstruction. And this one was nice and classic because it had the central calcifications. So this came to us as an outside CT where it was called all sorts of things, NET with calcifications. I think the take home point, like you said, is MR is definitely the way to go with these, and the T2s definitely help. It looks very ugly. It's probably one of the biggest cyst adenomas we've seen.
Yeah, that's a beautiful one. And I totally agree. Like on the CT, a lot of people will call it lots of different things, but that central scar calc is a huge clue, and the rest of it looks so cystic. So we know better. We're going to recommend the MRI. Okay, Nelly, want to go?
Yeah. Okay, I'm gonna, so this patient came to us with this. It's like, pretty big lesion. We had a follow-up, and patient had a follow-up fusion biopsy. It's a Pirates 5 lesion in the anterior transition zone, maybe anterior fibromuscular stroma. And it came back negative, the fusion biopsy. So what are you guys going to do next? Here's the sagittal version. Oh, let me pause this really quick because it's giving me this MPR thing, which I don't want. So, okay, so yeah, so there was that Pirates 5 lesion. And on the sagittal, you can see it's high up in the base right here, right by the bladder neck. Negative fusion biopsy. So what do you guys do now?
Repeat biopsy.
Yeah, I think it's still suspicious.
Yeah,
They go
sure.
transurethral and biopsy maybe?
Transurethral. Can we do that?
I don't know. I'm asking.
It's-
It seems so easily accessible from inside.
Yeah, transurethral. Yeah, I don't know if we have transurethral, but I know we have MR guided biopsy. And so, oh God, that's what this patient had. Sorry, 1 second. So this patient, went on to get so we have an in-bore MR guided biopsy system here. So that's there's a better one that shows it in the target right here. And then this came back as clinically significant prostate cancer. I think it was a 3+4 or a 4+3. So I'm going to show you this paper written by yours truly on the performance of MR-guided, in-bore MR-guided prostate biopsy. And the important take-home point is that it's really great for these hard-to-reach places like the anterior lesions, especially like the ones high up in the base, and that it's the other advantage in addition to those hard to reach places is you can during the in-bore you can actually see other lesions that you might not have originally seen. So we had a few cases in this case series where they saw a second lesion that was biopsied and came back as clinically significant tumors. And the yield is very high. And it's, we're classically taught that 70% of cancers are in the peripheral zone. But I think in actuality, I think that was like really a limitation of the path, like because we didn't have MR or the technology certainly wasn't there at the time. And I think that the distribution is really not so low in the transition zone. I think we just never really saw it or like paid attention to it. But now that we have MR, we see all these lesions in the transition zone. So
that's interesting, Nelly. So you think the percentage is changing?
I think so. Yeah. Because it was pathology bias, right? And the pathology in the past have just really, certainly for the biopsy, have always been kind of limited mostly to the peripheral gland, which are accessible with ultrasound guided biopsy. But now that we have MR, we're seeing all these lesions in the transition zone that we were probably missing before.
Cool. That's a good example. Should I show one more?
Yeah, that sounds good.
I'll show one quick one. Okay, here it is. Audience participation requested. Patient is a young 30-year-old female. History withheld. So I'll point out one thing, which is she has a lesion here in her right rectus muscle.
Do you have the sagitals?
Yeah, I can show you. And I'll just show you or point out that there is the soft tissue here in the mesentery encasing these vessels.
Is this FAP, Aarti?
Yes, Roopa, good job. And why did you think that?
The colon's absent and looks like we have desmoids in the mesenteric and the abdominal wall.
Yeah, so this is a great boards case because the clue is in the imaging, right? So you can see the small bowel, but the colon is missing. So why did this young woman have her colon removed? She had FAP, and FAP and Gardner's are both associated with desmoids. So this is a more infiltrative desmoid in the mesentery here. And then she has this other desmoid in the rectus muscle. So whenever I see rectus lesions, I always think about desmoids and endometriosis. This could have been a C-section endometrioma. That would have been a huge one. But given her history, that's definitely gonna be a desmoid. And it kind of also shows you that desmoids can be well circumscribed and nicely kind of rounded, but they can also be very infiltrative. These ones in the mesentery can be very difficult because they can cause bowel obstructions. They're encasing vessels. I mean, this is basically not resectable. So they're kind of watching it. Eventually they can, if these desmoids progress, they can treat them with steroids, methotrexate, radiation occasionally. They don't like surgery because it can cause can recur very easily. So I just thought it was a good case. And actually you can see here too, she's got her ilioanal J pouch from her colectomy. So this is her J pouch, side to side anastomosis of her small bowel, anastomose to her anus here.
I think it'd be so amazing if you could give us board review for the residents, Aarti, but I'll talk to you offline for that.
Sure, I will. Okay, I'm going to stop recording.